Let's go full textbook teaching mode on necrotizing fasciitis, moving step by step from definition all the way to treatment in a way that would make sense if you were sitting in a med school lecture. 1. Definition: necrotizing fasciitis, NF, is a rapidly progressive, life-threatening soft tissue infection involving the deep fascia and subcutaneous tissue, leading to widespread necrosis and systemic toxicity, commonly called flesh-eating disease. High mortality, 20 to 40%, even with prompt treatment. Num2 etiology. Two major types. Type 1, polymicrobial, most common, mixture of aerobic and anaerobic bacteria, Bacteroides, Peptostreptococcus, E. coli, Klebsiella, Enterobacter, Streptococci, Staphylococci. Often occurs post-surgery or in diabetics. Type 2, monomicrobial, usually group A beta hemolytic Streptococcus, gas, sometimes with S. aureus, can occur in healthy individuals after trauma. Less common, type 3, Clostridium species, gas gangrene-like presentation. Type 4, fungal causes, rare, immunocompromised. Number 3, pathophysiology. Entry point: skin breach, trauma, surgery, insect bite, IV drug injection, ulcer. Bacteria enter subcutaneous tissue. Bacterial toxins, e.g. streptococcal pyrogenic exotoxin A, streptolysin O, cause microvascular thrombosis of small vessels, ischemia and necrosis of fascia and fat. Infection spreads rapidly along fascial planes, up to 3 centimeters per hour. Nerve destruction, loss of sensation in late stage. Systemic inflammatory response, septic shock, multi-organ failure. Number 4. Risk factors: diabetes mellitus, most common, immunosuppression, HIV, chemotherapy, steroids, peripheral vascular disease, chronic kidney, liver disease, alcoholism, recent surgery or trauma, injection drug use. Number 5. Clinical features: early stage, hours day 1, severe pain out of proportion to visible skin changes, early hallmark, erythema, swelling, warmth, fever, malaise. Progressive stage, day 1-2, dusky discoloration of skin, bullae, serosanguinous or hemorrhagic, skin anesthesia over necrotic areas. Advanced stage, crepitus, gas-producing organisms, foul-smelling discharge, dishwater pus, septic shock, hypotension, tachycardia, altered mental status, multi-organ failure. Number 6, diagnosis. A. Clinical. Diagnosis is primarily clinical, high suspicion needed in at-risk patients with rapid progression. B. Laboratory. Leukocytosis, elevated CRP, hyponatremia, metabolic acidosis. LRNX score, laboratory risk indicator for necrotizing fasciitis, uses CRP, WBC, HbNA, creatinine, glucose to assess risk. 6 equals suspicious, 8 strongly predictive. C. Imaging. CT scan, fascial thickening, gas in soft tissues. MRI, most sensitive, shows hyperintensity along fascial planes on T2-weighted images. Do not delay surgery for imaging if high suspicion. D. Definitive. Surgical exploration, gray necrotic fascia, no bleeding, thin foul fluid. Number 7. Management principles. Medical emergency, treat like a surgical sepsis. Early recognition plus aggressive intervention improves survival. A. Surgical. Urgent surgical debridement is the cornerstone. Multiple serial debridements may be required. Amputation if limb salvage impossible. B. Medical. 1. Broad-spectrum empiric antibiotics start immediately. Piperacillin tazobactam, imipinum, meropenem, clindamycin, inhibits toxin production in gas aureus. Vancomycin, cover MRSA. Alternative, ceftriaxone plus metronidazole plus vancomycin. 2. Supportive care. Aggressive IV fluids, crystalloids. Vasopressors if septic shock. Nutritional support, glycemic control. 3. Adjunctive. Hyperbaric oxygen therapy may help in some cases, especially clostridial infections, but not a substitute for surgery. Nom 8. Prognosis. Mortality, 20 to 40%, higher if delayed 24 hours. Poor prognostic factors: advanced age, delayed surgery, immunosuppression, trunk involvement. 9. Key USMLE exam pearls. Pain out of proportion equals suspect NF. Clindamycin equals inhibits bacterial toxin production. Do not wait for imaging if suspicion is high. Diabetes is the single most important risk factor. Surgical debridement is the life-saving step. Antibiotics alone are insufficient.